medical updates, COVID-19 and diabetes, medical doctor Eric J. Pazeski, our Jewish chaplain, employee health medical doctor at Good Samaritan Medical Center.
I like that. Your jacket and mom's coat are matching. That is unbelievable.
Oh, thank you.
He's
They're going to think you're twins.
Oh, yeah. Except we have what, like 30-something years difference, 40 years difference. Oh, awesome.
30 years to do that.
I know, right? All right. So we want to put on the screen our wonderful, wonderful medical doctor, Eric J. Pazeski, MD, Jewish chaplain. Eric J. Pazeski, MD, is board certified in internal medicine and palliative care. Dr. Pazeski provides both inpatient and outpatient care for adults in his internal medical practice with a special interest in geriatric medicine. His clinical interests include management of acute illnesses, chronic health concerns such as hypertension, high cholesterol, and diabetes management, functional medicine, preventative medicine, and physicals, as well as general medical care and procedures. Dr. Pazeski received his medical degree from the University of Florida, College of Medicine in Gainesville, Florida. He went on to complete his residency training at Good Samaritan Medical Center in Phoenix, Arizona. He's currently serving as Employee Health Medical Director, where he uses his skills in functional medicine to help prevent and treat COVID-19 infections in the 1,600 employees of MJHS.
Right.
And he is outstanding, and his work stands for itself. We've traveled together. We have been friends for years, and he is just a fantastic. At this point, I want to hand it over to you, and you can take it away.
Thank you very much. It's a pleasure to do whatever I can to help keep people well. So today we're going to cover some brief changes in the way we look at COVID, and some brief changes in the way we look at diabetes to help everybody with these two issues. Some of this is quite new, but if you follow the news, you may have heard of most of it. If you could go to the next slide, please. So just to review, COVID-19 is a coronavirus that has gone through multiple mutations and is likely to continue to do so until vaccination is worldwide. So that's why it's important, even though we want to get COVID improved here at home, it is absolutely essential that we vaccinate all people. That's where all the new mutations are coming from, the unvaccinated people in the world. So anything we can do to get more people vaccinated will reduce the mutations that we are seeing. Current vaccinations have protected for up to 8 months, but after that, boosters are now needed. And so if you're past 8 months of your standard COVID vaccination, getting an antibody, getting your highest antibody levels requires the booster vaccination. They did look at all the different vaccines, and it turned out that Moderna did the best at increasing antibodies levels, but not significantly better than Pfizer. Both are fine. Janssen and Johnson & Johnson one and done was supposed to be the one vaccine that would do it all with just a single vaccination. It hasn't quite worked out that way. And now the CDC recommends that anyone past 2 months of the Janssen or Johnson & Johnson vaccine get a booster. And they suggest using either Moderna or Pfizer for that booster. So that's sort of the update in terms of vaccination. Next slide, please. We look at new variants of COVID-19 by how well they can infect others before someone's diagnosed and put into treatment and that terminates the spread of the disease. The initial COVID-19 virus was able to cause 4 infections in an individual before that person was put into treatment. And that was considered high, but then the Delta virus was able to cause between 8 and 10 infections per infected person. And it was also more virulent. In other words, it caused more death and serious illness than the initial COVID-19 virus. The Delta virus was. Now we have Omicron. Omicron is now more transmissible. So probably to the tune of 11 to 12 individuals are infected before a person gets into treatment. But it has not been shown to be any more virulent than Delta. So although this may be easier to share, it doesn't yet appear to cause worse problems in the hospital than Delta. And Omicron has more mutations than Delta and spreads more rapidly. But so far, the antivirals that we use against COVID-19 and the vaccines seem equally effective at Omicron as they do at Delta. So although we may develop new vaccines in the future, the current vaccines are seen as quite adequate to help us with Omicron. And we know that Omicron at last count was in 19 states and is probably in more at this time. Next slide. So COVID or any infection is a combination of how much of the infectious agent you're exposed to, i.e., how many copies of the virus did you inhale or get in your mouth, versus how well is your immune system and how well is your immune system functioning. I favor maximizing everybody's immune function, and this slide tells you how to do it. And I'm more than happy to have these slide decks shared with everyone participating today. So we found that there are 4 behaviors that are helpful in preventing viral infections. The first is to hydrate with fluids, and I like to keep it simple. I'm not going to tell you how much fluids to take. I'm not going to tell you what fluids to take. Just take enough until your urine runs clear and not yellow. As long as your urine looks like the water that you can drink, then you're well hydrated, and that's where we need you to be. So we need very well hydrated people to fight COVID-19. We need you to eat more fruits and veggies because this boosts the antioxidants level, and the antioxidants are what helps the body fight COVID-19. Sleep is an essential part of the immune system, and without sleeping adequately, your immune system will not function well. So we want everybody to sleep 8 hours per day or to nap to catch up. And if you can't do this all the time, please do it if you're infected, because this will very much help you. And the last thing is something that's rather interesting to discuss, which is everyone taking an alternating temperature shower, which means you go for a minute as cold as you can go, and then 3 minutes as hot as you can stand. And then you repeat that 1 minute of cold and 3 minutes of hot 3 times in a row. And you do that twice a day. They did studies on people who had saunas, mostly in Scandinavia. And these people stay in their sauna until it gets too hot for them. And then they jump into the snowbank naked and run around back into their house and go back in the sauna and do it several times. And we know if we got, say, 100 mothers and polled them, they would say these people would get terrible viral illnesses, lots of colds, might die of pneumonia. It turns out when these people were studied, they had bizarrely low levels of viral illness. And when they looked at their blood, the hunter killer cells were at a very high level, and the hunter-killer cells were much more active than in a standard person. And this is the mechanism for temperature change and how it supports immune defense when dealing with viruses. So we tell everyone to take an alternating temperature shower, a minute of cold, 3 minutes of hot, repeated 3 times, twice a day. Now we have vitamins and supplements that support immunity. We know vitamin C is very important, and we recommend 1,000 milligrams per day. We know vitamin D3 is very important, and we recommend 5,000 international units. That's about the most you can get in a gel cap once daily. We also recommend zinc 50 milligrams because when zinc goes into the cells, it prevents viruses from replicating, which is what we want. Now, there's another medicine called quercetin, which is made from fruits and vegetables. It's just a supplement. It comes in 500 milligram capsules. These are all over the counter. We do not need prescriptions for any of these. And you take 1 capsule twice a day if you're trying to prevent it. But if you're infected, I would recommend you boost to 2 capsules twice a day. So quercetin is a natural substance that enters cells and opens them to absorb as much zinc as possible. And so it's an ionophore that raises zinc levels in your cells to prevent viral reproduction. And then NAC, which is N-acetylcysteine, comes in a 1 gram capsule, or a tablet really, and you take that twice daily. And that is a strong antioxidant that helps your body fight the infection. So these are things anyone can do to increase their immune system. I think you can do it all the time, or you can do it when you learn you've been exposed. And I would certainly do it if I learned I was infected. Before we had other things, this was all we used. And in my facility, it was effective for 400 different people who were infected. So very, very helpful. If we can go to the next slide, there are now some new things that have come out that I think will really change the game. And in addition to maximizing your immune system, help you. So number one is an antibody infusion called Regeneron, which is 2 different antibodies that are made in large quantities that you get by infusion. So this is very expensive, and you have to either get it through an infusion, which takes an hour or 2 at a hospital, or get it at 4 different sites through a subcutaneous injection, which is somewhat uncomfortable. However, this is the agent that took former President Trump from almost needing a ventilator to being able to drive around in his limousine to his supporters. And it's very effective in positive individuals at preventing worsening or hospital admission. So this is now available at most hospitals that treat COVID, but you need to get it as an outpatient. So if you're at high risk for COVID, when you get COVID, this is a particularly good thing to get. Now, there's 3 new things that are much more pleasant and are available. So recent studies have shown that fluvoxamine, which is a drug normally used for compulsive disorder and anxiety disorder, 100 milligrams twice a day for 10 days reduced admissions and death. Death was reduced 90% in the group that took the fluvoxamine instead of placebo. And admissions were reduced 65% And this is a generic medication that is about $4 per dose. So this is the current thing that's available, and it's very reasonable, and most people tolerate it very well. So this is what we're using to try to hedge our bet and keep people at risk away from the hospital. There's 2 new antivirals. Merck came out with molnupiravir, and that looked to be something that prevented maybe half. Now the data looks like 30% of people who would be hospitalized are prevented from being hospitalized with the molnupiravir. Honestly, the fluvoxamine data looks better. If I was on a desert island and molnupiravir, the Merck product, was available and fluvoxamine was available, I would take the cheaper fluvoxamine because it works more effectively. However, Pfizer has a product that they seem to be able to launch soon. It's called Paxlovid. Okay, and it's another antiviral, okay, and it prevented 89% of hospitalizations versus controls in its studies. So that looks like it will be the most effective oral agent that we have when it comes out, but it hasn't yet hit the market, but I assume it will soon. Next slide, please. So I think the most important thing we can do right now is to get vaccinated now. And vaccination does have side effects in certain individuals. It does give them maybe something that feels like a flu for a day or two. It can cause pain where the injection is given, and that may last a day or two. But that is nothing compared to 2 weeks or 3 weeks or worse of the Delta variant of COVID-19, which is what you'll get if you're not vaccinated. So I really think vaccination is critical. I also think anyone who's 6 months past their last vaccination should get boosted, okay? And as I said before, ability to boost antibody levels, Moderna got to the highest levels. I think if you're able, boost your immune system with the 4 behaviors and the 5 vitamins and supplements we talked about before. If you're indoors outside of your nuclear family, if I'm indoors at home, I don't wear a mask. But if I'm indoors at a meeting, or I'm indoors at the supermarket, or I'm indoors at the ball game, okay, I think wearing a mask is quite prudent, okay? If you're outdoors and you're vaccinated, you don't need to wear a mask. But that's if you're all by yourself, if you're riding your bike or jogging. And when you get stopped by a neighbor who wants to talk to you, you need to stand at least 6 feet away. And if you can smell a neighbor, you can inhale their microbes. So if you can smell someone, that's the sign that your mask should be on. If you're in the uncomfortable position of having to care for a person who is positive, I think it's important to use an N95 mask and learn how to adjust it properly, because that's the only mask that will protect you if you're in close contact with someone who's positive. Okay, I think we can go to the next slide. It should be close to the last. So what is coming in the future? I think we need to watch for new nasal vaccines. Normally, nasal vaccines produce very high antibody levels for a prolonged period of time. So they look like the perfect way to get these vaccines in. I think we're going to see more antivirals to treat infections. I think you're going to see that testing kits are going to proliferate. Hopefully, they'll be as common as toilet paper, but you should be able to go almost anywhere and find a test that you can do to find out whether you're positive or you're not. Currently, PCR tests, which are the gold standard for testing and are the most sensitive tests to find COVID for people who are sick, hopefully will be resulted in an hour or two instead of the current several days that it takes in many places. Those are things I think we should see in the future. Now we're going to switch to a discussion of diabetes, because that's a fairly common disease and something that there are some new agents for. And we just have to find that new slide deck, which is Diabetes 2022 Update. But I think diabetes is so common that it's something that we really have to look at closely, what we can do to prevent diabetes. And when we have diabetes, what we can do to effectively treat it. And that's what I'm hoping to discuss with you. Okay, if we'd like to open it for some questions, I'm more than happy to answer them in the interim.
Yes, if you have any questions, please be sure to add in the chat. I think it's been really wonderful what you've been sharing, Dr. Pazetsky. And I'm personally, I can ask a question actually, because I was very curious to know more about the nasal vaccines. Do you know necessarily how they would be administered?
Yeah, I can't even tell you the names of the nasal vaccines. I just know that there are several in phase 3 studies, and it's very likely that we'll see one in the next year or two. And because of the history of nasal vaccines creating very high antibody levels, it's likely that they'll be useful with regard to COVID.
Fantastic. Thank you so much for answering my question, Dr. Pazetsky.
Now we'll do diabetes update. So on the diabetes update, there are two types of diabetes. Type 1 is an autoimmune driven diabetes that's related to the HLA types of immunity. So everyone has their own HLA type. There's about, I think, 70 or 80. And when you have the right HLA type and you get an upper respiratory infection and your body reacts to it, you form an antibody that you want to stop the upper respiratory infection, but it has the side effect of also being targeted against obesity cells. So these are often young children or young adults that have an upper respiratory infection and then suddenly get problems like urinating too much, not having enough energy. And when they look at them, they find that they have very high blood sugars because they've killed the beta cells in the pancreas that make insulin. And these diabetics need insulin to survive. So those are the type 1 diabetics. And that's fairly rare, probably less than 1% of diabetics. The second type of diabetic is our topic for today. And it's a mismatch between the insulin capacity and the cellular resistance to use insulin correctly. So as we age, we have our cells get what we call oxidized. That means that sugar and other things bind to the cells and basically make it harder for them to behave appropriately. And when that happens, insulin resistance increases. At the same time, sometimes the body's ability to make more insulin decreases. And when we have this mismatch, that's when we get type 2 diabetes. And the way that's often seen is in people who are obese, who have a high carbohydrate diet, or who are not very active. So that's where you pick up the most type 2s, okay? Although normal people get type 2 as well. I'm just saying there tends to be a relationship between obesity and lack of physical activity in type 2 diabetes. Next slide, please. Okay, so old treatments for type 2 is what we're discussing now. Old treatments were insulin, and it has a place in controlling severe out-of-control diabetes, but it's falling out of favor because it causes weight gain and hypoglycemia. And weight gain is something we don't want in diabetics, at least most of them. And hypoglycemia or low blood sugar can be fatal, and we want to avoid that. The other agent which is falling out of favor is a group called the sulfonylureas. Those are oral agents that reduce beta cell life and cause significant hypoglycemia. So even though they help control blood sugars, they do it at the expense of the beta cell, which is what makes the insulin that they force to be pumped out. And they increase the risk of hypoglycemia. So sulfonylureas are falling out of favor. There's these alpha glucosidase inhibitors, which were minimally effective, bile acid sequestrants, which were minimally effective, metaglinides, which were minimally effective, a group of agents called the TZDs that were associated with worsening heart failure and cardiac issues, which we don't want in diabetics, and metformin, which is actually still used and is now a candidate for a longevity pill. So metformin is still in great use. It's the only old treatment that's been carried forward. Let's see the next. So these are the new treatments that I think are going to pretty much revolutionize the way we treat diabetics with type 2. And I think this will be a real game changer in helping those people live more normal lives. Incretin-mimetics are unique agents that activate binding sites for 2 peptide hormones. It's kind of funny. They gave people glucose water orally, and they charted the insulin activity, and the insulin activity went up just a little bit with oral glucose. And then they gave them IV glucose, and the insulin went up really high, and the blood sugars went up really high. So what they knew is there was something that happened when food went through the gut that made the blood sugars more controllable than when it was just given intravenous. And what they found is that these two agents, GIP and GLP, which are produced in the gut when food passes by, are great for helping control insulin levels outside of mucking with insulin itself. And at first, these were twice a day injections, then they were daily injections, then they were weekly injections, and now there's one oral agent. So they've really changed what happens. But there's 2 significant reasons why these incretin-mimetics are falling into favor. One is they cause significant weight loss, about 20 to 30 pounds a year in the average patient. And we don't have anything else that does that. And it does it fairly safe. The second thing is it significantly reduces cardiovascular risk. And anyone who's a diabetic has double the cardiovascular risk of a non-diabetic. So these people are at very high risk for heart problems. And that's why these agents are favored. So I have some of them written below. Rybelsus is the only oral agent. Biduron is a once-weekly injection. Ozempic is a once-weekly injection. Trulicity is a once-weekly injection. Victoza is a once-daily injection. Adalectin is a once-daily injection. And Byetta is the first one, which is twice a day. So these are mostly by injection, but there's now an oral agent. We probably will see more. And these agents are great, again, because they help control body weight. They help control appetite. They greatly reduce cardiovascular risk. And for that reason, these are becoming a prime agent in treatment of type 2 diabetes. Next slide, please. There's a new agent which hasn't yet come out. It's called tirzepatide, and it's made by Eli Lilly. But this agent blocks 2 different sites, the GLP-1 and the GIP. So it gives you dual action. And in studies, it has dropped the hemoglobin A1C up to 2.6, which is pretty much unheard of for any agent we currently have. So it's very powerful at reducing poor diabetic control. It's also the most effective at causing weight loss. Now, when you start these agents, you need to be clear with patients who are used to taking and eating massive quantities of food, that you're going to convert them to a bird where they eat small meals. And that's the only way to do it, because if you start to feel full, the next thing you're going to do is vomit on these medications. They don't let the stomach empty very much. They let it fill up. So as a result, we have to warn patients that when they feel full, please stop. And it does really reduce the amount that they eat. And it does really improve the way the beta cells function. And it controls their diabetes and it helps them lose weight. Now, there are agents called DPP-4 agents, and they block the enzyme that breaks up the naturally occurring hormone GIP and GLP in the body. So these agents are minimally effective at lowering A1C, like 0.5, but they don't have any side effects. They're pretty benign. There's the new class, which is the SGLT2 inhibitors. These are agents that act via the kidney to dump sugar through urine. They have an intermediate lowering of A1C, but they have been shown to be cardioprotective, and they also induce very mild weight loss. So Pharaxa, Ivocana, Jardiance, and Stelagro are the 4 agents currently approved. Invocana is falling out of favor because it seems to increase amputations, and we don't want that in diabetics. All create a slightly increased risk of urinary tract infections and fungal infections, largely because they increase the amount of sugar in the urine, and that, when it sticks around, is easier to cause fungal growth. But this significantly improves the cardiac risk of diabetics. And so given the high rate for cardiovascular disease and stroke, many people are now calling for everyone who's a diabetic type 2 to get a GLP-1 agent, one of the ones we just discussed, as well as one of these new agents, because the two of them produce the best protection at preserving the pancreas, reducing the risk of stroke and heart attack, and controlling body weight. And that's something we haven't had the ability to do before. Next slide. So, what's the future of diabetic care? I think people are getting much more effective at what we know to be beta cell transplants. Well, here, let's do this first. What to do in a supersized world. If you go to fast food, you'll note that size has creeped up everywhere. Size of the entrees, size of the starches, size of the drinks. And this is what you can do to try to control body weight and control carbohydrate load, which is related to your likelihood of developing type 2 diabetes as you grow older. So I'd say buy great food, fruits and veggies, eat it raw, steamed or air fried, buy quality wild fish and meat if you want to. I would say eat the fruit, don't drink the juice, because your gut needs the fiber, and the fiber is what makes you feel full. When you're outside of the home and buying meals, try to buy quality meals that are mostly fresh, steamed, or sauteed veggies. God took only 1 day off. You can take 2 days off, but do try to exercise at least 5 days a week for 40 minutes. You can walk, you can do the stairs, you can get a 10K step counter if you wish. These are all ways to increase your own physical activity. But make it part of life so that you don't feel the drudgery of having to go to a gym. You don't have to do that. You can do it on your own, do it in your own neighborhood, and do it for free. There is no minimal carbohydrate amount. No one ever says you need X amount of carbohydrates, because you don't need carbohydrates. You can make your own carbohydrates from the excess fat and protein that you bring in. So I tell people, slay the carbohydrates if you don't need them. You don't need the rice. You don't need the potato. You don't need the bread. You can have them if it's important for what you're eating, but the carbohydrates are something we can reduce. And the other thing we can do is drink unsweetened drinks, because those unsweetened drinks, okay, are far healthier for us than the full sugar drinks. I think the other thing that you can do is realize that things are supersized. And when a big meal comes, split it in half. Ask them to wrap the half that you're not eating, and then have a more reasonable sized meal. And then if you're growing and unable to stop, please find a weight loss specialist or functional medicine specialist. That'll help get you on a diet and a lifestyle that'll help you control your weight better. Next slide. I'm here to answer any questions, and I'll take questions at this point for the time that we have left. I would say that someone asked about controlling triglyceride levels, I believe, and lipid levels are valuable to control.
Okay, we have one question.
Cholesterol and triglycerides. Yes, go ahead.
Her Excellency Kyra has a question.
Oh, I already asked a question. Did you have a question for him? I know Dr. Willis had a question as well.
Yes. How do you deal with we have diabetics in our family, but they just love sugar and starch. I don't know what to do. What do you suggest that we do without bullying someone to eat properly? They'll hide cakes and buns in the couch and under the bed, ice cream and stuff like that. What do you do with somebody like that?
Well, it's pretty tough if you've got someone that, I mean, we do want people to have the ability to enjoy life and splurge at a rare time, but that does not require them to squirrel away carbohydrates. So what I would say is if you have someone who doesn't have the discipline to reduce carbohydrates in their meal, you may want to look at trying to get them on one of the incretomometics, because no matter what they eat, this will reduce the amount and will help them lose weight regardless. So if you have people who continue to eat things that are not good for them, aside from trying to work with a dietitian to work with them and go over what they are doing and see if they can get them to change. If we can't do that, then I think the next best thing would be one of those new incretomometics that will help them limit their intake. And there's that new dual agent that's coming probably in the next 2 or 3 months, which might even be better for those sorts of people, but we won't know that for a while. So at this point, I'd say one of the GLP-1 agents. Okay, there was a question about fixing slightly elevated LDL cholesterol. It's really something that you need to talk to your doctor about to decide. Some people get good LDL lowering with red yeast rice supplements, which but you want one that's professionally done, and I favor the ones that you can get through Costco. But you can take red yeast rice. You can take a statin, although statins sometimes cause some muscle discomfort in individuals, so you have to try one and see if it works for you. But they are very effective, and you can try to lower the. I think those are the two best means of probably trying to control the LDL cholesterol. I think other things like fish oil help other cholesterols and triglycerides, which may help a little bit. But to truly lower LDL, you're either looking at something like red yeast rice, which is something you can get over the counter, but you need to do in conjunction with your doctor, or a statin, which is a prescription drug.
Excuse me, Dr. Eric, His Excellency Dr.
Any other questions that would be useful?
Yes. Dr. Willis said he had not a question, but a comment.
Yeah, I want to say on behalf of everybody here, Dr. Eric Brzezinski, thank you so much. Information was on point. We were able to understand it and the way that you explained everything, and it was really great advice. And this is not embarrassing, but I will say that it was great seeing you at the class reunion 41st. And so that means I've known you since I was 14. That means that.
Yes.
What 18 years? 18 years? No, I'm sorry. What am I saying?
I know why you think it was
44
great
years.
to see me, because you brought your wife and she looked like the teenager of the gang.
That is so true. And she's aging backwards. I'm aging forward. I don't know how that works. But
Well, you're not aging forward that much. Don't worry, we'll catch up.
Thank you so much. Everybody
That's a-
give
oh, yeah.
Dr. Eric. Yes, thank you so much. Thank you so much.
Thank you so much for your time. I look forward to keeping everyone well.
Yes.
And please send my decks to everyone who wishes. And if you'd like to contact me privately, you're more than welcome to send me an email or call me.
Awesome. I'm going to
Sounds
send that person who's having some issues with. I'll send them directly to you. Thank you, Dr. Eric. God bless you.
Thank you.
All right.
Thank you.
Please have a great meeting. And I wish everyone the best.
Thank you.
Thank you. You as
Blessings.
well. Thank you.
Love to Jordan. Love to Jordan.
Yes, always.
That's my other son. Yes.